Okay, welcome everybody. Thank you so much for joining today's webinar. My name is Kimberly Brunel, and I am the Ontario Regional Support Liaison for AMAC. And if you don't know us, AMAC is a leading funder of research into bone marrow failure diseases in Canada. Our organization supports patients and caregivers from across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. I am so pleased to be joined today by Dr. Michelle Geddes. Dr. Geddes is a hematologist and clinical associate professor at the University of Calgary and Tom Baker Cancer Center. As of right now, the lines are muted. If you have questions throughout the presentation, I encourage you to type them into the chat box or the question box. Just put them in as the presentation is going, and we'll be sure to answer them by the end of the session. Today's webinar is recorded and will be made available on our website. So without further ado, I'm going to pass it over to you, Dr. Geddes.
Thank you. So I'm Michelle Geddes. I'm one of the hematologists at the Tom Baker Cancer Center in Calgary. I have an interest in myelodysplastic syndromes and in acute leukemia, and I'm also a stem cell transplanter. And I was asked to talk today a little bit about understanding MDS risk scores. So this is something that you guys might, or that people may have come across in their MDS journey. Often when you were initially diagnosed with myelodysplastic syndrome, you sort of realize that it's a blanket name for actually what's probably a number of different bone marrow failure problems. And some of them can behave quite differently from others. So some of them will be very slowly progressive or indolent. Some can be much more quick and can turn into problems with acute leukemia, or people can become transfusion dependent and with multiple blood cell lines low. So we do have some ways that we can try to predict how somebody's myelodysplastic syndrome might behave. And this is really why we use some of these risk scores. So I'm going to try to walk you through a little bit of an introduction as to how we approach these today and how it might relate to your situation. So I'm going to give an example of a very, typical patient who might come in. So Mary's a 66-year-old woman who has come in with fatigue. She's found to be anemic, and she has a low white blood cell count. So whenever we see more than one cell line down, the red cells, the white cells, or the platelets, we start to think about a problem with the factory that makes the blood. So that's the bone marrow. And so she had the appropriate test done when there was no other obvious reason for why her blood counts were low, things like bleeding or other problems. She had a bone marrow biopsy done so we can look directly at that factory and see how it's working. And she's told she has a myelodysplastic syndrome with excess blasts 1. And the question is, what does that mean? There's so many different names of different myelodysplastic syndromes that are out there. They can behave differently. And how might we try to determine how this might behave? So what could be, in her future? So we can talk a little bit about myelodysplastic syndromes in general. We know that this is still considered a fairly rare blood problem, but it's getting more attention as we now have more ways to intervene in the disease course, more treatments that are available. And I think sometimes people who may not have gone through a full workup, like getting a bone marrow biopsy done and trying to find the cause of it, are now getting more complete workups than they were 10 years ago, because we now have ways that we can intervene if we find this. So we estimate more than 350,000 patients have myelodysplastic syndromes worldwide. And in Canada, somewhere between about 10,000 and 40,000 patients have been diagnosed with MDS. So somewhere around 1,800 to 6,000 new cases every year, often in patients who are over the age of 65 years. So why do we not know how frequent this is, or how can we make this better? So there are some initiatives that are going on across the country. And one of them is the Canadian MDS registry. And so this is a national registry that's being done to try to capture the frequency that people are diagnosed with MDS, so it's called the incidence, and look at some of the prognostic factors and disease factors and treatments, and actually look at quality of life and how we're doing with treating MDS. So this would actually be, if you're not already on the registry, something that would be interesting to talk to your physicians about, see if you want to be a part of this. It's completely optional, but it is providing us a lot more information about how extensive this problem is across the country, and we're learning a lot more about the disease because of this registry. So when, what kinds of patients have a higher risk of getting myelodysplastic syndrome? So interestingly, more men than women are diagnosed with myelodysplastic syndromes, and we don't know entirely why that is. On average, women do tend to live longer than men, but yet the incidence is somewhat higher in men, about 60%. So that's not well explained. Also, we know that MDS affects people of all races, but the incidence is highest in white individuals, and we don't understand that very well either. So this is another reason for doing active research. And we also know that it is more common as people get older. So the median age of diagnosis, that means if you have 100 people diagnosed with MDS and you rank them from lower age to higher age, the 50th person would be about 76 years old. But as you get over the age of 80, the incidence goes up dramatically. And that's one of our issues when we're looking at managing this, is to say, well, are people well? Do they have other health issues that might interfere with the ability to manage their myelodysplastic syndromes? So what are risk factors for developing MDS? Because we don't know 100% why people get it, but it does help us to predict sometimes too why it can behave. Most people, we don't find a clear cause, right? And so when we say it's de novo, that means it comes out of the blue. There's no pre-existing blood problem that turns into MDS. We look at specific risk factors. So one is things like environmental risks and lifestyle, and I'm going to go through that in a little bit more detail. So we know that there are certain things like organic solvents, benzenes, which is often found in the oil and gas industry. So certainly something we see a lot of in Calgary, but also people can, use this if they're working in paint shops or sometimes through hobbies. Can increase that risk. Cigarette smoking increases the risk by about 2 times. So it's a fairly small increased risk when you look at a fairly uncommon disorder. But that risk continues for about 15 years from the time of quitting, and then it goes back down to baseline. The other thing that can predispose to developing myelodysplastic syndrome is if you have had previous chemotherapy or radiation, and we call that therapy-related disease. And the reason for that is those treatments, they're designed, the idea behind them is to try to affect the rapidly dividing cancer cells, but we know that they can affect some of the normal cells as well. And sometimes people will get DNA damage to those cells that can progress and develop a myelodysplastic syndrome, sometimes even many years later. So that's about 10 to 15% of all patients with myelodysplastic syndromes. And we know people with a therapy-related MDS are generally considered to have higher risk disease, tends to be a bit more resistant to treatment and progress a little bit faster than average people without previous treatments or therapy. And then finally, there are certain families that have a history of blood cancer. So they may be a history of myelodysplastic syndromes or acute leukemia in those, acute myeloid leukemia in those families. And some people have underlying disorders where they have chromosome instability or DNA fragility, where they are at more risk of developing cancers, including myelodysplastic syndrome. And interestingly, a high body mass index. So people who are overweight can increase that risk, have increased risk. So this is data that comes from the SEER database. So this is the large epidemiology database out of the United States. And it looks from the years 2013 to 2017 to say, during that time period, what's the ages of people who were diagnosed with myelodysplastic syndrome? And you can see that it can happen at any age, even in childhood, although it's quite rare. But after the age of about 55, that the frequency of diagnosis of MDS goes up quite a bit. And that goes up especially higher once you get into your 70s and 80s and 90s. So the older you get, the higher that risk becomes. And that comes down, that again has some impact on how easily we're able to manage this, and also how symptomatic people are depending on what other health problems you have. So if you have underlying heart disease, for example, you might have more symptoms from anemia than somebody who doesn't. So there are lots of things that people looked at to say, does this maybe impact my risk of developing a myelodysplastic syndrome? And sometimes it's very hard to tell for things that are kind of widely present in the environment. So things like fertilizers or wood dust or dyes or exhaust gases, things like that. It's hard to tease out who's had higher risk than others. And is this an association or is it a cause? So for all of those, when we look at the adjusted odds ratio, that means how much more likely are you to have MDS if you have high exposures to these things? So we can see that exhaust gases, there's actually no difference. The adjusted odds ratio is 1. So it's the same for if you've had lots of exposure or not. But for petrol, it's about 2.5 times more likely. Radiation, about 2.25 times more likely to get MDS if you've had those exposures. But there are certain high risk professions, and that's the chart on the right. So we know that people with these professions have statistically significant increased risk of developing myelodysplastic syndromes. So that's those p-values less than 0.05. Those are the statistics on the right. So things like agricultural workers, so more exposures to pesticides and herbicides, textile operators, so specifically higher risk of exposures to things like clothing dyes, health professionals. And so this is a well-known risk, for example, in nurses who administer chemotherapy. And that's one of the reasons why your radiation technologists will be wearing Geiger counters and be tracking their radiation exposures over time. You can see smoking is a lesser risk, but it is still there, along with commercial and technical sales representatives and living by an industrial plant. So common signs and symptoms of MDS, this by itself doesn't necessarily tell us how this is going to behave. We know that some people with kind of an indolent MDS may just be having routine blood work and be found to have blood numbers that are low with red cells or platelets or white cells or more than one, but actually have no symptoms, and may not require transfusions and may go for a long time without requiring any treatment. And that tends to be a good thing. And when we look at the signs and symptoms of MDS, it's often related to these low blood counts. So if you have low red cells, you may be feeling fatigued or generally weak, lose some sense of well-being, be kind of pale, shortness of breath, especially when you're exerting yourself. So going for long walks or going upstairs. But if you have low white blood cell counts, you may have more frequent or more severe infections. You may have fevers, for example. People with low platelets may bruise or bleed more easily. People sometimes just lose weight and appetite. They sort of have some failure to thrive just from feeling unwell from all from the myelodysplastic syndrome activity. So this is just a quick summary of some of these symptoms with low blood counts I went over with a little bit. So we know that anemia is the most common thing we see in patients with MDS. Most patients with new diagnosis of MDS will have anemia. And we talked about fatigue and feeling weak or shortness of breath, but sometimes people feel like, especially when they're exerting themselves, they feel like their heart is beating in their chest, or might, if you're prone to heart disease, may have chest pain. People with low platelets, that's found in about half of patients with MDS, and that can be the bruising or bleeding that we talked about, and that can be anything from gum bleeding or nosebleeds to bruising in the skin, heavy periods, or sometimes things like hemorrhoids can bleed more, or if you're prone to GI bleeding, that can bleed more. And low white blood cells are seen in about half of patients with MDS, and again, the risk is infections and fevers. So to make a proper diagnosis of myelodysplastic syndrome, we do need to do a bone marrow biopsy. And this is where we take a small sample of the red marrow from inside the bones. And we tend to use the hip bones because those are easily accessible. It's a fairly safe place to go into. And when we take these samples, we take both an aspirate and then a small biopsy from inside a hollow needle. And we can look at that under the microscope and do stains for cells to say, are these are these myeloid cells, or these lymphocytes that are abnormal? You know, what kinds of cells are there? They can run the cells through a machine called a flow cytometer, and it looks at the markers on the cells to see if they're abnormal and looks at the number of immature cells. But we also do some things that are really important for myelodysplastic syndrome, which is actually culturing the cells overnight and taking the dividing cells and looking at the chromosomes specifically and looking for any chromosome abnormalities. Usually these are not chromosome abnormalities that you're born with, but these are acquired in your lifetime and are linked to the cancer directly. Same with molecular testing. So this is now routine. Most places with diagnosis of MDS, I think across the country, it's routine, and Ontario's had the toughest time getting this done. But I think this is happening or going to be happening across the country. And again, looking usually at acquired mutations at the DNA level. So not looking at a whole chromosome anymore, we're looking at the DNA sequences in those chromosomes and looking at specific mutations that we know are associated with myelodysplastic syndromes. Most of the time, these are also acquired and not something that you're born with, but there are some that can be inherited and can predispose to myelodysplastic syndromes. So this is what a bone marrow biopsy looks like on the left. You can see these big cells that look like these are platelet precursors. We can see other cells that are white blood cell precursors, like neutrophil precursors, and they can get more and more mature with these little horseshoe-shaped cells. And then we can also see red cell precursors, which tend to be round, and often these are a bit misshapen in myelodysplastic syndrome, so they don't look 100% normal. And they also can take a little sample and spread it out on a slide and take a look at the individual cells and look for cells that are funny. So we can see here a neutrophil that looks funny. It's got a funny nucleus and it's missing all the granules we normally see. And some of these red cells look like they're funny shapes. And so this is a bone marrow that's trying to make blood, but it's making abnormal cells and it's being very inefficient about it. So these are not getting released out into the bloodstream, and the blood counts in the bloodstream are low. So this is an example of what a karyotype looks like. So the technicians will grow the cells, plate them out, and actually find the chromosomes and match them up. So they sit in these rooms and they can find, you know, the 2 chromosome 7s and the 2 chromosome 11s, which to me look very much the same, but they will find them and match them up. And they can even say, oh, well, look here, we've got a piece of chromosome 9 stuck onto a piece of chromosome 11, and find some of these abnormalities where either bits of chromosomes are missing or we have extra chromosomes. So somebody might have 3 chromosome 8s, for example, or 3 chromosome 21s instead of the usual 2. Or you can find that sometimes part of one chromosome has been stuck onto another one. So this one, for example, this is a male patient because there's an X chromosome and a Y chromosome, both. So why are the chromosomes important? Well, 2 reasons. One is this can impact diagnosis. So sometimes when we're not entirely sure what's going on, when we grow up the chromosomes, we see certain chromosome abnormalities. We can say this is diagnostic of a myelodysplastic syndrome. Even if the bone marrow itself, the cells look funny but aren't quite enough to make that diagnosis. So it's very helpful in that way. But we know that at least half of patients who have an MDS that just happens without having previous radiation or chemotherapy or a prior bone marrow problem will have at least 1 chromosome abnormality. And that also helps us with prognosis. In patients who have therapy-related disease, so previous chemo or radiation, that actually goes up to about 90% of patients will have at least 1 chromosome that's abnormal. And so you can gain additional chromosome material, or sometimes you lose some, and it affects how you make your cells and whether you're able to make cells normally or not. So when you're initially given your diagnosis of myelodysplastic syndromes, we know that there are different types of myelodysplastic syndromes under that kind of umbrella term of myelodysplastic syndromes. And some of them tend to behave a little bit better than others. So when we have a myelodysplastic syndrome with a single lineage, so only one cell line that looks funny under the microscope, it looks dysplastic, that tends to behave a little better than if you have multiple cell lines that are dysplastic. So for example, if it's just red cell precursors that look funny, and the platelet precursors and the neutrophil precursors look good, that tends to be better. We also know that sometimes we can see cells like called ringed sideroblasts. So this is an example of a picture of ringed sideroblasts. So you can see that this is a red cell precursor that still has a nucleus on it. It has little iron staining molecule particles all around that nucleus. And that makes a specific type of myelodysplastic syndrome that tends to have generally quite a long associated survival, so good prognosis, but patients do get anemic, and many patients do require transfusions for a long time, even years. And we do have new treatment options of things that now may help reduce that need for transfusion. So there's been things like erythropoietin or darbepoietin, so synthetic versions of a hormone that the kidney normally makes to tell you to make your bone marrow to make more red cells, but now also other growth factors that work at different parts in that factor, in that pathway, something like luspatercept that tends to do really well in patients with ringed sideroblasts. So that's a helpful thing for us to know. Getting a little bit more concerning is this myelodysplastic syndrome with excess blasts. So we know a normal blast count on average is around 3% or less, but we consider up to 5% to be okay. But if you're getting a higher blast count, kind of 5 to 9%, that tends to be a little bit more worrisome, tends to be a bit higher risk of developing leukemia or bone marrow failure. And if you're getting an even higher blast count, so between 10 and 19%, we call it MDS with excess blasts 2. And that tends to be even a little bit higher risk, more risk of developing acute leukemia, which is what we call a blast count of 20%, right? And so those patients we tend to treat more quickly and treat differently than people who maybe have lower risk disease and ringed sideroblasts, for example. There's a specific disorder called myelodysplastic syndrome with isolated deletion 5q, where you're losing a little bit of the tail of chromosome 5. And that has a very specific picture. People tend to do quite well with it. People on average live for many years, more than 10 years usually. And it tends to respond well to different kinds of medications. So we put that in its own little category. So the type of MDS you have can tell us already a little bit how this could behave. Now, what about these chromosome abnormalities? There are many, many different chromosome abnormalities that can happen in myelodysplastic syndrome. So some of them we know are associated with good risk. So these can help us. These can be prognostically important. So for example, if you have a deletion 5q, so that bit of the tail of chromosome 5 is missing and you don't have any other chromosome abnormalities, usually this behaves very well. And we can, you know, people can live their lives and we manage it, but has very good prognosis. Same with the people have missing a piece of chromosome 20. And for all the men here, it's not actually that unusual to see men lose one of their lose their Y chromosome as they get older. So that does not mean you have myelodysplastic syndrome if you have that, but people who just have that tend to do quite well. But we know that there are other things that are high risk and they have higher risk of developing leukemia or bone marrow failure and not as good survival. And that can be things like having 3 or more chromosome abnormalities of any kind, or missing part of chromosome 7, or losing a whole chromosome 7, for example, can be higher risk. And here we have about 45% who have just normal chromosomes, about half of people with MDS that happens out of the blue, where the chromosomes actually aren't helpful. And we say, well, that's a good risk. You know, it's better than, you don't have the really good risk, you don't have the high risk. So it's sort of a good risk category to have that. So when we look at the clinical features, the people have looked at big groups of thousands of patients and said, okay, what features in this patient, on these patients that do seem to predict how the MDS could behave? So what are the features of prognosis? So one is the proportion of blasts in the bone marrow. So that's a really important one. And that tends to especially help with predicting the risk of developing acute leukemia. We also can look at the chromosome abnormalities and we can divide them into good risk, you know, or adverse risk, like different risk categories. And so that can be helpful. And then we look at just how low are the blood counts. So is the hemoglobin just slightly below normal, or is it very low where you're needing transfusions, for example? Or same with the platelets and the neutrophils. Are they just mildly low or are they very low? And those can be very helpful in predicting how this could behave. So other things we talked about, if this is secondary MDS, so if you've had previous chemo or radiation, that's not as good. We also look at molecular risk factors. So this is a relatively new thing I'm going to talk about a little bit because it's just being built into our prognostic scores right now. And we're just learning how to use this in the clinic. Things like whether there's a lot of scarring in the bone marrow on the biopsy and whether you actually need transfusions or not can be important. So the most common risk scoring system that's used right now is something called the IPSSR. So this is the International Prognostic Scoring System, and it's revised from a previous version. So this one, this one looks at specific parameters. So it says, looking at your chromosomes in your bone marrow, do we divide this into either chromosomes that we think have very good risk, good, intermediate, poor, or very poor? Same thing with looking at the marrowblast. So we said usually under 5% is okay. An average is 3% or less, right? So they say if you're at 2% or less, that's very good. And if your blast count is between 2 and 5% in the marrow, that's still good. 5 to 10% is intermediate, starting to get to be high risk. And if you have more than 10% blast, we say, well, that's a high risk situation. We also look at the hemoglobin. So if your hemoglobin is more than 100, you tend to be lower risk than if you have a hemoglobin of less than 80 without transfusions. Same with the neutrophil count of 0.8 or more, and platelet count. So if you're less than 50, it's not as good as if you're more than 100. So we can actually plug this into online calculators, look at all the numbers, and it gives us a score. So you get a certain number of points for each of these. And it puts people into either very low risk MDS. So this is where in the days before we had specific treatments for this, the median survival is about 9 years. So that means if we can never say for any one person what could happen with any of these scoring groups. But if you take 100 people that have the same risk score based on risk factors that you have, half of them will be alive and will not have developed leukemia at 9 years. Okay. Whereas if it's very high risk, that is less than a year before half of people are alive and haven't developed leukemia. And if we look as well at the average time it would take for a quarter of people with those risk factors to develop acute myeloid leukemia, if you have high risk disease, it's actually less than a year. It's about 0.7 years, about a quarter of people will have developed leukemia. But if you have low risk disease, it's about 11 years before that happens. So these scores are meant to be used at diagnosis only. So this is not something where you go back and say, okay, I've had MDS for 2 years. Now I want to plug it in and see how this is going to behave now, because that isn't really valid to do that. You know, it's not a very good predictor in that situation. It's just sort of saying at diagnosis. Also, this doesn't really apply to therapy-related MDS, which is always kind of felt to be a higher risk category on its own. And those patients weren't included in the studies that did this. So we also need to know that these are outcomes that were pertained to before we had interventional treatment. So this is before we had really therapy for MDS. So this is patients who are not transplanted, patients who didn't get hypomethylating agents like azacitidine or decitabine. And so this is important to understand. This tells us a little bit about the natural history of sort of untreated myelodysplastic syndrome that happens out of the blue. And these are the risk factors that we think are important. It's the chromosomes, the blast count in the marrow, and what your blood counts look like. So with that, we can actually draw a bit of a curve. So we can say, well, there's a certain point at which half of people will be alive and free of leukemia, but this is kind of a curve that develops over time. And so if you can see for people with very low risk disease, people tend to be alive for quite a bit longer. And then compared to patients who have very high risk disease. And this helps us to guide how aggressive we want to be with treatment and what kind of risks we're willing to take with treatment. If we can predict, this disease looks like it's going to behave well versus not well. And it doesn't mean that if you have very low risk disease that you might never need treatment, but you might not want to start it right away. You might wait until it's starting to cause problems, for example. And then if you look at the risk of developing leukemia, so this is the proportion of patients free of leukemia. If you have very low risk disease, you can see that even at 10 years, only a very small number of people have actually developed acute leukemia. Whereas if you have very high risk disease, that the risk of developing acute leukemia is much higher, much smaller group of patients are free of leukemia down the road, and it happens a lot sooner. So there does seem to be a plateau in that curve, and that probably relates to, some patients who, small number of patients who maybe have good long-term outcomes that are a little bit unexpected because nobody reads the books and knows exactly, we can never predict for one person what could happen, or potentially people who may have had curative treatments like transplants. And we also know that age matters too. So even if you have very low risk disease and you're 40 years old and you think, I want to do something to cure this, your outcomes actually over time are better are better than if you were over the age of 60. And that probably has a little bit to do with different characteristics of the disease itself more than anything, and also something to do with other health problems that people may have, So people do tend to do better if you're younger, even with the same risk factors. So finally, we've started to learn about specific point mutations in the DNA, certain gene mutations that are important in helping us to both diagnose myelodysplastic syndromes, especially in situations where it's not entirely clear what's going on, but also especially to help with prognosis. And this is a very evolving field, but you will probably hear, if you ask, you may hear about different mutations that have been found on the cancer cells. And again, most of these are mutations that you have acquired in your lifetime in people who have developed MDS. There are people walking around who have these mutations who do not have MDS. And in fact, some of these mutations are shown to increase the risk, for example, of cardiovascular disease or certain types of cancers. And so that may go with just a higher risk of inflammation and other things in the body that can predispose to MDS and to other health problems. So just having these mutations for most mutations doesn't diagnose you with myelodysplastic syndrome, but it can help us to predict how people might behave if they do have myelodysplastic syndrome, how the disease might behave, and can be prognostically helpful. And in some specific situations, it helps with diagnosis. So the problem is there are over 30 genes that we consider to be driver genes. So we think these are causative genes that are contributing actively to patients with myelodysplastic syndromes, to their disease. And none of them are very frequent. So, and then mixed in here in red are different chromosome mutations that can happen as well. So in blue are specific gene mutations. And so you can see the highest, most common ones are still under 25%, under 1 in 4 patients. So none of these are found in everybody with MDS, right? And it does seem to matter which mutations are develop, like who their neighbors are. So if you have one mutation associated with a specific mutation, they might do better or worse than if you just have that mutation alone, or you have that mutation associated with a different one. So it gets complicated, and how we're interpreting this is something that we're still learning. So we know that a typical MDS patient has a median of 2 or 3 mutations. So those are the most common number of mutations that people will have. Not everybody has one, but the vast majority of people do. And the higher risk MDS patients tend to show higher numbers of driver mutations than lower risk MDS. So what do these mutations mean? Well, a little bit we can sort of divide them into different pathways. They tend to have a number of mutations which will all work in different mechanisms, like in specific pathways that we think are important in myelodysplastic syndromes. So for example, a bunch of mutations are all important for signaling, where cells will signal to each other different things. Some mutations have to do with epigenetic changes. So this has to do with the three-dimensional conformation of the DNA and whether all the transcription factors can actually get to the DNA that they're trying to transcribe, for example. So they might be blocked by methyl groups that are blocking the DNA from being transcribed. Things like splicing, how you stick your messenger RNA together before you ever make proteins out of this. How things are transcribed, also DNA damage. So can you repair DNA damage if you have it? Or are you more prone to having DNA damage? So there's pathways, and different mutations can all affect that same pathway. So we talked about how having more mutations tends to be, or having fewer mutations tends to be associated with better risk with myelodysplastic syndrome than if you have a lot of gene mutations. So some of them actually can be good. So if you look at this SF3B1 mutation in blue, which is what we often see in patients with ringed sideroblasts, that is actually a good prognosis mutation, and people do better if you have that mutation than if you didn't have any mutations at all. And then if we look at outcomes of all people, regardless of their chromosomes and all of their other risk factors who have no mutations, it's better than if you have 1 or 2 or 3 or 4. So the more mutations you have in general, the more the disease can cause problems. This is a complicated chart, which you don't need to, which I'm just going to try to explain very briefly, to say there are a number of mutations that seem to influence overall survival, okay? And that is patients, or that is the gene mutations that are above this red line. So all of these different gene mutations impact overall survival. The SF3B1 impacts it in a good way. These other mutations tend to increase it in not as good of a way. Okay, and they have different frequencies. So the ones with the bigger circles are more common than the ones with the little circles, which are actually quite rare. And so about 42% of all the MDS mutations actually seem to impact how people do with MDS. And so, and the point is, mutations can be good or they can be bad. So not all mutations are a bad thing. It does seem to matter. So then we go into this molecular international prognostic scoring system. So this is where things are going. This is very hot off the press. This was just published at the American Society of Hematology meeting in December of this year. So this is coming out of New York. There's a large group that's looked at molecular mutations and how does that interact with those clinical factors that we talked about earlier, like the blood counts and the chromosomes and how many blasts people have in their blood. And so they can find that there is an association between some of these gene mutations and how people do in terms of overall survival or the risk of developing acute leukemia. And they combined these with people's age, their gender, their type of MDS. So is it therapy related or was it happened out of the blue, and their IPSS-R raw score, so that was the blast count and the chromosomes and the blood counts from before. And they found about 15 genes that were important and impacted outcomes. And so it did seem to matter what the genes were, but also what's the pattern of other mutations that were co-mutated with that. So it's not just a gene by itself, it's also what other genes have been mutated. And they plug this in. So they found in all about 17 different variables, then they found another 15 genes that were kind of informative, but not as important. And they plug it into this really complicated equation, which all of you can just plug into, take your numbers and plug it in right now and figure it out. Just kidding. They're doing an online calculator that does this for us. And they can use that to try to come up with a score that can help predict outcomes. So this is the molecular IPSS-R score, or the molecular IPSS score that has just been published. And so if you look at this, this can nicely separate out sort of curves for overall survival and developing leukemia in patients with myelodysplastic syndrome. So this is another way of helping us to refine how we can predict how people's myelodysplasia might behave over time. They did compare it to the previous IPSSR score, and this gives you an idea of sort of something called a C-score. So it tells you how the higher the bars are, the better it correlates with how people actually do. And both their initial group, and then they took a large number of Japanese patients and just checked it again in that group. Both of them, the leukemia-free survival, the overall survival, and the risk of developing leukemia were better predicted using these molecular markers, as well as the clinical markers that we've been using all along. So there is a web calculator, and that actually reclassified almost half of patients to a different risk group. So this is going to be where things are going. The other thing that's super cool is machine learning. So this is looking at artificial intelligence, because when you have all these different gene mutations and they could be impacted by what other gene mutations happen with them, this gets very complicated. They actually can get computers to do some complicated scoring to be able to put it all together and say, how for this one person, what is our best predictor for how this could behave? So there's this study, for example, is ongoing. They're enrolling 8,200 patients. They've actually already finished accruing to it, and they're doing analysis over about 4 years. And so this is going to be published. They've also been publishing like just sort of some early data showing some really good prediction of how people are going to do based on combining the clinical scores and some of these molecular tests, but using computer algorithms to try to put it all together, and including how all of these genes interact with each other. So how's this important? That all sounds complicated. And in the clinic right now, really what we're using is the revised IPSS. We're using blood counts, we're using chromosomes, and we're using a blast count. And we're adding in people's age and looking at that. And then there are certain molecular genes that we tend to say, okay, this tends to be associated with higher risk or tends to be associated with better risk, that might help us to make decisions. Because really what we want to do, or what we tend to do early on, is we say, okay, when you're coming in the door, does this look like a higher risk myelodysplastic syndrome, or does it look like a lower risk myelodysplastic syndrome? And that's important because when we look at the treatment options that we have and how effective they are, you know, who they tend to work on, and the risks that people want to take, that can be different depending on whether people have low risk myelodysplastic syndromes or high risk myelodysplastic syndromes. So people who have low risk MDS might have quite a long expected survival, but they may have low blood counts that can give them symptoms. And so the goals for people in lower risk MDS may be trying to improve the blood counts, trying to prevent needing blood transfusions, trying to prevent iron overload because of blood transfusions, for example. We also look at quality of life. So is the treatment that we're offering, does it have a lot of side effects? Is it going to make you feel better, right? And then we also think about, can we delay progression of the disease and improve survival? And there is always a goal of cure, but when we talk about our curative options of treatment, they have a lot of toxicities, and offering those treatments too early in the course of somebody's journey with myelodysplastic syndrome is sometimes associated with worse outcomes than offering it later when the disease is causing more problems by itself. For higher risk myelodysplastic syndromes, that can be quite different. So people who have a shorter expected survival with the disease or a higher risk of developing acute leukemia, that changes the discussion, where you might say, you know what, this is the risk of the disease, this is the risks of the treatments that we have to offer. You know, what are our goals? Is our goal to delay disease progression? Is it we want to try to improve survival if we can? Ideally, we'd like to cure everybody. And right now, our only curative option is a stem cell transplant. So that is tougher when you have a patient population that might be older. If you're in your 80s, a transplant is generally not a really good option, for example. We also still want to reduce that disease burden. If we can, make the blood counts better so people aren't needing transfusions, aren't getting infections, aren't feeling sick, and staying out of the hospital if possible, right? We also want to look at the tolerability, but we're willing to accept sometimes more side effects if the disease itself is causing more problems. We were sometimes willing to accept more side effects of treatment. And I would disagree with this. I think quality of life is important no matter what we decide. And that's always a part of the discussion that we have. So for example, for patients with lower risk disease, if people are not symptomatic, we may just watch and wait, right? And watch carefully, but we may not be doing anything to try to change the disease at the time it's initially diagnosed. But people, if they do have symptomatic anemia, and so they're saying, I'm tired, I'm more short of breath, or I might need blood transfusions, then we do look at trying to do interventional treatments. And so people with the deletion 5q can get treatment with lenalidomide, which is sort of a newer generation of the old thalidomide drugs that tends to be really effective at improving red blood cell counts in people with that deletion of chromosome 5. Without that, sometimes we'll use erythroid stimulating agents. So those are agents that help they're synthetic versions of that hormone that your kidney normally makes to tell your bone marrow to make more red cells. Sometimes we'll give immunosuppression, and some people will just give transfusions and do some iron chelation to take the iron out if we need to. For patients with higher risk disease, then we look at this and we say, well, is this somebody who would be well enough to do a stem cell transplant for potential cure? And is this something that they're interested in doing, right? And if they are, then we might start looking at doing a stem cell transplant. And often patients will need some sort of treatment in the meantime. And we use things like azacitidine or decitabine to try to keep things at bay, or often, of course, clinical trials. And if people don't want to do transplant, then we use those kinds of options to try to delay disease progression, hopefully improve blood counts, make people live longer, knowing it's not curative. So this is kind of how it helps us to sort of say, is this somebody with lower risk or higher risk disease? If we do a stem cell transplant for somebody with lower risk disease, overall survival is actually pretty good. If people have a higher chance of surviving and being cured than if you transplant people with high risk disease. However, studies have been done comparing outcomes in people where they're transplanted right away for low risk disease, or transplanted at the time that the disease changed and became some high risk features. And people actually tend to live longer and live better not doing a transplant up front, because those risks are higher than the risk of the disease up front, but they may go to transplant later on. So this is just kind of a framework of how we can use these prognostic scores to say, how do we approach managing patients that have these disorders? And this is always I put this slide up sometimes just like this, with transplant, we're between a rock and hard place, and that we know that transplantation is the only curative therapy for myelodysplastic syndromes. But we know that the median age at diagnosis is around 65 to 70 years old, and the toxicity of transplants go up as you get older, and it can be prohibitive to offering this kind of treatment for some patients. And so only a minority of patients actually go on to do this kind of treatment. And that said, I'll put a plug in to say there are a lot of clinical trials that are open and accruing or coming that are looking at new treatment options, some of which will target specific mutations that we think are higher risk, that are non-transplant options that may turn out to be effective and change what we do down the road for patients. So always in those algorithms we put up, we also want to include clinical trials. So that's just a little bit of an overview of what does an MDS risk score mean? We can never use those scores to come up with a number and say, this patient is going to live this long or has this risk, this will develop leukemia at this time, because it's not how risk scores work, and we would always be wrong. All we can do is sort of say, you know what, if we took 100 people with the risk score that you have or the risk factors you have, at what point would half of people have run into problems or have developed leukemia? And so that's how we use those, and it helps us to guide a little bit where we are moving forward. So I really want to thank you guys for your attention and open up the floor to questions that people might have. And I put here, I like this, if you look online on Pinterest, they have these really cool like science cookies and things like that. So some people have made like just really fun cookies. These are all blood cells here. So here's a neutrophil and a red blood cell and a basophil and like another, like or eosinophil and neutrophil. So lots of white cells here. And I just think it's kind of fun. So I put that up just as a background.
Very cool. Thank you so much.
Yeah.
Gotta find where I can get a hold of these cookies.
I know, right? Some people are so creative.
Yeah. So I'm welcoming everyone to take a moment now to post your questions in the either in the chat box or the question box. I see there's some there already, but if you want to start typing, you have some time to do that. Or if you really don't want to type your question and you'd prefer to have yourself unmuted and ask your question, you can also raise your hand and I can do that as well. So I'm not sure, Dr. Geddes, can you see the chat box?
I can, yeah, I can see one in
Okay.
the chat and one in the Q&A.
We have a question in here from John. I'll read it just in case folks
Sure.
can't see it. I have low risk MDS. IPSS score is 0. Diagnosed in December. Red cell issues only. Latest hemo at 10.2. I'm clinically obese. Generally speaking, since this is a factor, is it possible to affect blood count by losing weight?
So having a bit of extra weight on board increases to a small degree the risk of developing MDS, although that's a fairly small increase in risk. Okay, so there's lots of people who have extra weight who don't develop MDS. Once you have it, we don't know that losing weight makes your red blood cell count better. And having a relatively low risk, so that's a really good risk score that you have, means that you could be living with this for a very long time. So it is always a good thing to be healthy and take care of all your cardiac risk factors, because you could live with MDS for many years and you don't want to be getting a heart attack or other problems. The other thing is, I'm not sure, how old you are, what your other health problems are, but if your disease changes over time, it can be over many years. So usually for lower risk MDS, we might just talk about using growth factors to bring the red cell count up, especially if that's the only problem that you have. But number of years down the road, if you do need things like hypomethylating agents or stem cell transplants or any of those things, you want to be healthy so that you can do those kinds of treatments. So I think just in terms of helping with energy and general wellness, having a healthy diet and a healthy weight is important, but I don't think it will make your red cell count go up. And I think there are many risk factors for MDS. It's not to say that this is why this happened. Okay.
Thank you, John. If you have some follow-up to that, feel free to post in the chat. Connie, I see your hand went up, but I'm just going to go to the chat, but I'll come back to you. Can you see the question and answer box?
I can. Do you want me just to read them out loud?
If you'd like, if you want to start at the top.
Okay, sure. So one of the attendees asked, thank you for the talk. Can you please speak to the long-term clinical significance of the DNMT3A mutation and the risk of MDS or AML in aplastic anemia patients? Is it a pre-leukemia state? And should bone marrow transplant be prioritized in a 30-year-old patient based on this abnormal mutation? That's a good question. And how each specific mutation affects outcomes with aplastic anemia is still less well studied than AML or MDS. So if you look at this mutation specifically, we know it's a bit of an adverse risk factor for AML, but it is something that can be overcome by transplant, especially you're talking about somebody who's quite young. That is one of the mutations that on this score here for MDS is not actually reaching that point where it's significantly affecting overall survival by itself. So it's below that red line where we say, we know it's there. It looks like it's probably not as good, but only just slightly to the right of the black line that we think makes a worse prognosis. And it doesn't actually hit clinical significance. So for MDS, it's not as clear at this time that that's a really bad one. And for aplastic anemia, again, I think it's really unclear. So there are other factors that are more predictive. So, if you are thinking about going to transplant, we tend to look more at how long has it been since you had diagnosis of aplastic anemia? Do you have a matched sibling donor? How low are your blood counts? If you opt to do immune suppression first, we look at, have you responded to that immune suppression? But I wouldn't use the DNMT3A by itself to make that decision for aplastic anemia. That's a really good question. So I hope that helps. Please feel free to add any follow-up questions if you have them. And somebody else had asked, do the hypomethylating agents extend survival? And the answer to that is yes. On average, they do. So this was really exciting when this came out. These are our first agents that really did seem to improve overall survival. And so in the big seminal study where they randomized people with higher risk MDS, so this is really just for intermediate 2 or higher risk MDS, or people with an IPSSR score of 3.5 or higher is usually where we will often say we start to use this. It improved the median survival by about 9 months in patients who were given azacitidine. There is another one out now. This is the oral D-cytidine, cedurazidine, and that one had another study where it randomized to kind of placebo. And that one didn't show as much of an overall survival, but it was a very different patient population that was being accrued to that trial. It was very heavily pretreated and sicker patients. And in real life, most people expect to see similar improvement in survival with both of those different hypomethylating agents. So they do tend to improve survival. They're not curative, but for some people, if we say the average time that people have a response to that is somewhere around 18 months or so, and it can vary. There are some people who will be on hypomethylating agents for much longer and doing well. So even for a number of years longer than that. So again, you kind of have to look, each person's a little bit different. So another one is where can we find the new molecular IPSS score calculator mentioned, or can it be done by specialists? So this is brand new. So they presented this in December at the ASH meeting, the American Society of Hematology meeting. And so they have said they're going to make it available online. It's not available yet, to my knowledge, unless it's been published in the last week or so that I'm not aware of, but it's coming in hopefully the next few months. So this is still something that is really cool. And once it's out there, we would like to use it, partly because it's been looked at in one patient group and then validated in another one. So it's been pretty well evaluated. But that one is very, very brand new. So that is imminently going to be published with an online website and a calculator that anybody can use. It's just not up yet.
We'll have to host something once the news breaks then. Yeah,
exactly. So next question is, how long do hypomethylating agents remain effective? So that's a really good question. In the first trial that was done, when they do studies, sometimes they'll pick patients who are really well to be on the original trials. And they found that you can't predict for any one person what could happen, but at about 2 years, half of people had progression of their disease to leukemia or had passed away from their myelodysplastic syndrome. So that means half of people are shorter, half of people are longer. And I think in real world, when we sort of say, okay, keeping in mind that in real world, we treat lots of people who might be sicker than people who'd be on a clinical trial or might have less fitness when they first start treatment. It's probably more like around 12 to 18 months. But that said, I've had patients have gone as long as 5 or 6 years. So it really does depend on the individual person. There's a relatively like a smaller number of patients where they can have a response for even quite a bit longer than the average time. So it's hard to predict for any specific person. Okay. So I think, was there somebody with a hand up that I should go to and sort of go back and forth?
I think the hand has gone down. Oh, Connie's there. Okay, hang on 1 second and I'll get Connie here. Okay. I see you, Connie. Just 1 second. Okay, Connie, I'm allowing you to talk. Can you unmute on your end? There you go. I got you, Connie. Go ahead, ask your question.
Okay, I am mainly considered, and Kimberly, you know this, I'm curious as to find out what with my high iron, I'm taking deferoxamine and my iron count is still going up. I'm way up over 10,000. by taking transfusions. I've had 151 transfusions.
Hmm.
So I'm just wondering what, if there's anything for that that's better to do.
Yeah, so and do you know if your liver enzymes are high as well?
My which ones?
Your liver enzymes? Yeah.
I don't think they're that bad.
They can make your ferritin higher. So the deferoxarox and deferoxamine, they're both iron chelators.
Yes.
So do you have a pump that you use?
No.
Or do you take the pills?
I just take pills, medication.
Okay. So you can go up on the dose of the pills. So sometimes people, you have to try to take the iron off that you got and then also keep up with the blood transfusions that you're getting, the iron loading. So you can go up on the doses of the pills. Sometimes people will get stomach upset or diarrhea. So you have to kind of find a meaningful thing that's there. And there are times when people will combine that with a pump for something like deferoxamine, which is another iron chelator that you can use together with that. If you're otherwise doing really well. But there is a bit of an inconvenience factor to that too, because of the fact that you have to have the pump going for most of the night, at least 5 days a week for it to be effective, like 8 to 10 hours a night. So that's something you could talk about with your hematologist. Yeah.
Dr. Zhu, yeah. Okay.
Yeah. You're trying to always create quality of life. And
thanks, Connie.
Okay. Thanks, Kimberly.
So the next question. So Catherine had asked, she says, I just diagnosed with low risk MDS. I'm 57, female, very active. Told I have a mutation in the RUNX1 gene and would like to know more about this gene mutation. I also find current developments in the IPSS scoring very interesting. Will you be sharing some of this new data with us after the presentation? So I think the IPSS scoring, the new developments really are around the molecular testing that we talked about. So that hopefully I've covered some of that there. And as these calculators become available, that will become more readily available. And same with the artificial intelligence. So those programs are being done in clinical trials, but they're not yet available to everybody in the clinic right now. But that's, I think, whether we end up using the IPSS-M, the molecular IPSS score, or the artificial intelligence, it'll be interesting to see what's better when they're kind of head to head. The RUNX1 mutation is interesting. So if you look at this table that I have up here, the RUNX1 gene mutation is one that does seem to significantly affect outcomes in patients with myelodysplastic syndrome. So it is a important prognosticator, and it isn't captured well in the previous IPSSR, but we do know it's a higher risk category. There are some families who have inherited RUNX1 mutations that can predispose to myelodysplastic syndromes and acute leukemia. So it would be useful to talk to your hematologist about what proportion, so it's something called a variant allele frequency. So what proportion of the cells actually have that mutation? So is it very high proportion or just a few of them? Because if it's a very high proportion, then you think more about whether it could be inherited. And they can do testing where they swab your cheek, for example, or you do a skin biopsy and just look at your skin cells to say, is this something that's just in your blood cells, or is it something that's in your other cells as well, which would mean that it might be that it's an inherited one. Okay. So for leukemia, it is also an adverse prognostic factor. And we know that we can overcome that with transplant. And so in somebody who's young and otherwise well, that may be something you'd be thinking about at some point in the course of your disease. And it does look like we can overcome that gene mutation with transplantation. So that's, I guess, a good side of it. So I don't know if that answers your question, but feel free to ask more if you have any. And then I'm just going to answer, I'll go back to Marva, just there's any new treatments close to being approved that could be used with higher risk disease. So there are a lot of things that are being studied. One of the ones that's very interesting is a drug called magrolimab, which is being used especially in people with high risk mutations like P53 mutations. So there are a lot of studies that are open for that one right now, or are about to be opening for both myelodysplastic syndrome and acute leukemia. There are also phase 3 trials that are open for drugs like TIM3 inhibitors like sotrovimab, and quite a few combination drugs. So I think one of the things we're going to probably see is combination of hypomethylating agents with a drug called venetoclax, which is a pill that you take, and it's been very promising in phase 2 trials to increase survival and remission rates in patients with myelodysplastic syndrome. So the phase 3 trials are just happening, and that's the last step that you need to get those approved. Those are already becoming standard of care for patients with AML around the world. And that's something that is going through the funding process right now in Canada. So I think that's probably where things are going to be going.
Interesting.
Okay. So I think the last question was, what's the risk of MDS following immune therapy for aplastic anemia? And does that risk plateau with time? So yeah, that's an interesting one. If you look at, I'm not sure if I can tease out the risk of MDS. If you look at the risk of developing an acute leukemia with an aplastic anemia, it's around 25% at 15 years. So as time goes on, that risk does go up. So you still have a stem cell that's a bit vulnerable that's there that can have accumulated damage. And that's why for younger patients who have a matched sibling, will often go to a transplant right away up front, because outcomes with transplant are really quite good in that group of patients. So I don't know that it plateaus with time especially, but I do think you're going to see some of the kind of bad players early on. So if you do opt to do immune suppression and not do a transplant up front, for example, and you do develop leukemia, then you would go under, or MDS, you would undergo the appropriate treatment for that disease, and you could go on to transplant at that time. And somebody asked if JAK2 is a positive or a negative predictor. For MDS, it's hard to say. It is, I think, on that scale that I gave you, or that, I almost didn't put this up because I thought it was too complicated, but I'm actually glad I did because I can refer back to it. It's not one of these ones that we see as a really big predictor in patients with MDS, although it's in that kind of, I think it's in the 17 genes for the molecular IPSS. There are some, so JAK2 is often found in a different family of disorders called myeloproliferative neoplasms, and there are some disorders that are overlaps, and somebody's just putting up a question about that. So an overlap between a myelodysplastic syndrome and a myeloproliferative neoplasm. And so there are specific types of disorders like a refractory anemia with ringed sideroblasts and thrombocytosis, so high platelets, that has JAK2 mutation. And those patients tend to do quite well, actually. And tend to maybe have problems with anemia, but not so much a high risk of developing leukemia and things like that. So it makes you wonder if there could be a bit of a component of an overlap disease when we see that. And so there are different, if we're going to talk about the MDS MPN overlap diseases, there are a number of them and they do behave differently. So the refractory anemia with ringed sideroblasts and thrombocytosis, that tends to have quite a good prognosis over the long term. People can tend to live for many years with that. There's something called chronic myelomonocytic leukemia, and that one can be variable. Some people will have a bit of a high white blood cell count, may have some anemia and either high or low platelets, and can live without needing any interventions for quite a long time. And there are some people with very aggressive disease where the white count goes very high, and we treat it almost like you would treat a leukemia. So it can be very variable. And then there's a whole bunch of ones that we don't understand well that we just call MDS MPN overlaps. And so we tend to treat them sometimes with ruxolitinib, so a JAK2 inhibitor. Sometimes we treat them more like MDS, depending on how they're behaving. I'm not sure if that answers your question, but there are a lot of different disorders, so it's hard to answer for the whole family. And they're not ones we understand really well, so we're learning a lot more. So if people, and this is again another shameless plug for the MDS registry, because I think it's been a really good resource for us to try to learn more about some of these diseases that we really realize we have lots to learn about these, and the research is really cool.
For sure. Sorry, I was unmuted and I was chatting away there.
Oh, sorry.
No, that's okay. Any last questions before we wrap up for today? Thank you so much. That was a wonderful presentation. I'm jotting down for you. There's lots of things I want to look up after this. Thank you so much.
Okay.
Thank you. Great information. A couple of comments coming through. So we'll wrap up for today. If you want to watch this back, if you have some questions further to the presentation, please feel free to contact us at AMAC, and we can put you in touch with Dr. Geddes, or we can answer the questions for you. This presentation has been recorded, so you can watch it back if there's something you missed. And again, you can find information on our website, amac.ca. So thank you so much again, Dr. Geddes. I really appreciate your time. Thank you so much, everyone, for coming, and have a great evening.
It's been a real pleasure. Thanks, everyone.
Thanks so much. Good night.